Hello, everyone. Today we're going to be talking about the normal newborn. And so this is going to cover chapters 17 and 18. I've combined them, and we're going to be focusing on assessment and nursing care of the newborn. So let's get started. So the first thing that happens after this baby is born, what we hope happens, is this baby goes directly to that mom's chest and starts that transition process. So the baby is moving from fetal circulation to external, and all the things that was happening for the fetus when it was in utero, now it has to do on its own. As long as the umbilical cord is still attached and is not clamped, and the placenta is still functioning, it's kind of this in-between time where it gets a little bit from the umbilical cord and placenta and a little bit of support as it starts moving oxygenated air or air through its lungs and start the oxygenation process through the lungs and moving that fluid out. So ideally, we're going to put this baby directly skin to skin with the mom so that we can allow that transition process to happen. We know that skin to skin is one of the things that helps the baby start to regulate its heart rate, regulate its temperature, regulate its blood sugar. There's so many things, so many good processes that happen. All that sticky vernix that's on the baby, the covering that's on the outside, will actually allow some of the bacteria from the mom's skin to stick to it, and then it starts to build its immune system. So it's really the best place. Now, if the baby needs some sort of respiratory support or resuscitation, current practice right now for most places is that they will clamp and cut the cord and take the baby over to a warmer, a radiant warmer, to start those processes. But I know there are some studies going on about leaving the baby attached to the placenta and cord and actually doing resuscitation with those support measures in place. And we'll see if that ends up being standard of practice or not. So again, at this moment of birth, when this baby takes that huge breath, it's moving from fetal circulation to outside life circulation, and it's going to start doing all of the things that the placenta was doing for it on its own. And sometimes that can take some time for it to work out well. So these are the changes that happen as we move from fetus to newborn. And you can take a look at these changes that are here. It's actually really interesting how all of this happens right at that moment. Like this is a pretty pivotal moment when that pressure off the chest actually releases as the baby is born. Then it allows the pressure change to happen in the lungs. The baby takes a big breath and then pushes all that fluid out of the lungs, closes that flap, that ductus arteriosus, closes that up, and we immediately start circulating through the lungs, where previously that wasn't happening. So interesting slide there. So here's some of the adaptations that happen over the next couple of days. Here's explaining what I just said in more technical terms, and you can take a look at that. One of the things that we see, the result of some of this process, is sometimes the baby, you will notice that they will start to change color. They turn from kind of that purplish, bluish gray to a pink color. And over the next couple of days, they may still have a little bit of bluish tinge to their hands and feet. That's called acrocyanosis. It's a normal expected finding. What is not normal is to have blue around the lips or the mouth, what we call circumoral. So those are one of the knowing what's normal versus what's abnormal and when we need to intervene. Important information there. So this is a slide that's looking at the changes that are happening from the fetal circulation. You can see where these arrows are. This is where we were bypassing that area to the lungs, and then that flap has to close up over time, and we will move through the lungs. It will be circulated through the lungs. And the same thing happens as it's going to the liver. There's another section that it was bypassing the liver for the most part. One of the processes that will happen as this flap starts to close, you might hear a audible murmur when you're listening to that baby. So there's some really good videos out there that you can listen to what murmurs sound like. Our textbook actually has a really good video that if you go into the course point section, you can hear the different sounds, and it's not uncommon to hear murmurs in those first couple of days. Now, usually if the baby is born in the hospital, a pediatrician will want to, or may want to get some further studies, echo, to look at what's going on in the heart to make sure there's not any other structural abnormalities. But you may hear that. So here's our summary of moving from fetal to neonatal circulation, and you guys can take a little look at that. Here are some blood values that are important to understand. You have to know what's normal in order to know what's not normal, especially here. We can go all the way up to 30,000 for our white blood cell count before we are really concerned about infection. Now, that's not the norm for your normal med-surg adult patient. And I've already said that for our pregnant patient, we have a higher threshold. We know that the white blood cell count does go up during labor, and so we have a higher threshold there. Again, that's going to be based on policy, but it's typically somewhere between, during labor, it's somewhere between 15,000 or so, 12 to 15,000 before we start to get concerned. But for a baby, we can actually go all the way up to 30,000. Platelet count is the same. Here's our hemoglobin and hematocrit levels. If we're really high in our hematocrit, then we are concerned that we are going to have an excess red blood cell breakdown, and that byproduct of the red blood cell breakdown is bilirubin. And we're going to talk all about jaundice in just a minute, but if we have a really high hematocrit, then we're going to be on the lookout even more so for the development of jaundice. So I talked about the respiratory system in previous videos, but really what you need to know here from this slide is what's normal, 30 to 60 breaths. We need to be listening for an entire minute because they can have periods of apnea for up to 15 seconds. And if you happen to be listening to them for just that 15 seconds, then you're not going to hear them breathe at all and think something's very wrong. So listening to respirations for a full minute is very important. 30 to 60 breaths is what our threshold is. If it's under that, we're concerned they're not oxygenating. If it's over that, it may be an early sign of infection or hypoglycemia or something else going on. So this is where our baby is going to tell us something's not right, and that our early signs are going to be with our vital signs. So it is our job as a practitioner to always look at vitals. That is our role. Know what's normal, and every baby you come in contact with, you need to be doing an assessment in your head and looking at those normal vital signs, because they have very subtle signs when they start to get ill. A newborn that is at term will have these alveoli that are opened, and that's what allows the gas exchange. What we are concerned about in a preterm baby is that they don't have enough surfactant at that point to hold the alveoli open, and that's where we start to see respiratory distress. So we're watching for that in that respiratory rate. The other thing that's happening to the respiratory function as they move from fetal to neonatal, you can see that the lungs follow along with the heart. We have lots of changes that are happening. And sometimes this can take several hours for that transition to happen. So we're watching, making sure the baby is oxygenating well, making sure that it's moving in the right direction. And then after a few hours, if they're still showing signs that the transition is not happening well, then they might need a higher level of care. That would be when they go into the NICU and have some further diagnostics. And I do have an entire video on babies that need a little extra help, and that's in another area. So other things that we are constantly thinking about is this heat loss. Newborns are predisposed to heat loss. So you will see that we are obsessed with temperature, obsessed with keeping this baby warm. These are the reasons why this baby has a predisposition to heat loss. and why we have to control the environment. So they cannot shiver. They don't have the ability to have voluntary muscle activity at this point. They have a very limited stores of glucose and very limited stores of glycogen and fat. And they have no ability to adjust their clothing. They can't communicate. Their skin is very thin. So lots of reasons that contribute to this. This is an NCLEX question. They love to ask you this: what are the mechanisms of heat exchange? And so conduction, convection, evaporation, and radiation. And you can see an example of these here. Conduction is when you put them on a cold surface. This is why we put a warm blanket down, or why we warm our stethoscope up before we put it on the baby's chest, or even put it on top of the t-shirt. That's acceptable. Convection is being in an open doorway, being under the air conditioning vent. Evaporation is just a natural process. And then radiation from a window, especially in those areas that are very cold, we have to think about, is the cold coming in through the window and potentially affecting the baby? The way we take a temperature is underneath the arm. When we put the thermometer under the arm, we want to make sure the end of that thermometer is not poking out the other side. There, you may see things, certain resources that you have may talk about during rectal temperatures. That is not recommended. It is not the standard of care anymore to do a standardized rectal temperature. It used to be, because we were looking for the patency of the anus, but there were just so many perforations and so much potential for damage that they have gone away from that. Now, we do still need to make sure there is patency there, and the number one way to do that is look for stool. But taking a baby's temperature, we need to hold the arm down because it needs to have a tight seal and it needs to be tucked way up in that arm. This is a radiant warmer. You will see these used in all neonatal areas. It doesn't look like it should, but it brings down the heat really well to this baby. You can't see this very well, but this baby has a temp probe on, and these machines are very smart. If you put the temp probe on the baby and it's held down with that little heart sticker, and set the temperature that you want the machine to be, it will keep track of what the baby's temperature is and raise the heat or lower the heat based on what the baby needs. Now, a couple of things. This has to be an uninterrupted view. It has to be able to sense what's going on, and so we can't cover the baby up. And oftentimes you will see grandmas or other family members in the room be concerned that the baby is laying here naked because, of course, they've been taught to be concerned about the temperature. So a couple of things. We never leave a baby unattended on a warmer. And if you're going to leave a baby on a warmer for an extended period of time, it needs to have a temp probe. Now, in the NICU, they can be on a warmer because the nurse is there in the close vicinity and they're on monitors. But when they're not on a cardiac monitor and we don't have any other way of knowing what's going on, we cannot leave them unattended in a warmer, because you can actually overheat them so much that they can cook. So I always tell my family members, please don't put the baby on the warmer and turn it on when I'm out of the room. It's not appropriate. The other changes that are happening are the hepatic system. We're going to spend a lot of time talking about jaundice. This liver essentially is just immature. And as we are asking this baby to break down the excess red blood cells it gets from its mom, different conditions may contribute to those excess red blood cells. Different conditions with labor and delivery may contribute to that. And we know that we are at high risk for a traffic jam and a buildup of that byproduct called bilirubin. Now, bilirubin can be cleared through the body, but in high amounts, it is toxic. And we'll talk more about that as we move into how we treat bilirubin. Gastrointestinal system. There's a development of a mucosal barrier that prevents bacteria into the gastrointestinal system. And one of the most important things we need to help build that layer is breast milk. Breast milk is uniquely adapted to help the development of that barrier. And unfortunately, bovine milk, which is what formula is made out of, bovine being a cow, has a very large protein that breaks down this mucosal barrier versus building it up. So this is why colostrum, that first milk, is so essential to babies. So even if somebody is planning not to breastfeed, if they can just give the baby that colostrum early on, it will make a difference. And there's always the opportunity to use donor milk if they have that available in their area. Their capacity, the newborn stomach capacity, is very small. And I'm going to talk about it in more in detail in just a minute, but we easily overfeed babies and then they will regurgitate it back up. We want them, they have to have a certain amount of calories per kilogram in order to gain weight. But for the first couple of weeks, we actually expect a weight loss. Now, we don't want it to be too high of a percentage, and we're keeping an eye on that, but we do expect a weight loss for the first couple of days, and then they should be back up to their birth weight by the time they are 2 weeks old. That's one of our normal values that we are looking for. So a baby on the first day of life, its newborn stomach size is about the size of a cherry, which is a teaspoon. So we shouldn't be feeding them 3 and 4 and 5 ounces because their tummies just simply can't handle it. And a lot of times I'll hear people say, well, I gave the baby a bottle and it was so hungry, it just sucked the whole thing down. And if you think about the physiology of it, when a baby is at the breast, it has to pull to get the milk out. Every suck it has to use to create a siphon and get the milk out of the breast. But when you give them a bottle, it literally pours down out of the nipple and they have to swallow to protect their airway. So yes, they will keep swallowing as long as the milk is flowing. So it's up to us to know what they need versus what they will do. They're not sucking down a whole bottle because they're hungry. They're doing it because they're trying to protect their airway and fluid is flowing into their mouths. So knowing stomach sizes are very important. The stools are very different. Starts off with this meconium, which is a thick black tarry substance. Sometimes this is passed even before they're born, and we've talked about that in previous lectures, but then it's going to change based on what they're being fed. And these are pictures of normal newborn stool. Now, this slide is probably one of the most important slides I'm going to show you because this is that thick, tarry black stool. And what we need to see in order to know the baby's getting enough is by day 3 or 4 of life, that stool needs to be changing. It needs to be turning into transitional stool. If we still have meconium, thick meconium, at day 3 or 4, this baby is not getting enough. Enough fluid, enough milk is not going into this baby. And we need to be looking at other reasons and helping this mom figure out how she's going to supplement these feedings. The other thing we need to know is that by the time the baby is a week old, so day 6 or 7, we need a minimum of 6 to 8 wet diapers in 24 hours. And a wet diaper should be at least a tablespoon's worth of fluid in that diaper. It should feel heavy. So we need a minimum of 6 to 8 wet diapers in 24 hours by the end of the first week. It's important to know your normals. I just basically said the same thing. But the other important part to understand about the renal system is that they have very limited ability to concentrate that urine, and they cannot tolerate being dehydrated in any form or fashion. So it is essential that we make sure that our babies are well hydrated because they can decompensate very quickly in just a short period of time. So as an adult or even as an older child, there's a certain threshold where they can go without food and water for a certain period of time, but with a newborn, we just cannot. So then when we talk about immunity, a natural immunity is built by being exposed to things. Well, these babies haven't been exposed to anything, and so it takes time for their immune system to build. The immune system is actually very complicated. We could spend an entire course just talking about that. But for our newborns, know that they do not have an immune system other than what they have gotten from their mothers. They get IgG and IgM from their mothers, and they are able to utilize some of those antibodies for the first few months while they are building their own immune system. This is why we ask moms for, it's IgG that crosses the placenta. I said that wrong just a minute ago. We ask moms to be vaccinated against the things that will provide some immunity to their newborns where they couldn't get it. So for instance, we asked them to do the DTaP, which is giving them immunity to pertussis. We asked them to do the flu vaccine to give these newborns some immunity to flu through IgG. And then now we're asking for the COVID vaccine. And it does allow some of that IgG to come through to the newborn and give them a small amount of protection. The other thing we need to be looking at is making sure that our babies are not exposed. We should not have them out into crowds of people. We should not pass them around. If someone is feeling ill, they need to stay far away from a newborn because this newborn literally has no immune system, has not built it up yet. So the baby is born with this thick, cheesy substance. It's called vernix, and this is what helps to protect its skin. It also, we have learned, helps to control blood sugar, helps to control temperature, and allows that immune system building, as I mentioned before. So we don't have to wash this off. Interesting fact is that this vernix seems to be inversely related to our surfactant. So what I mean by that is the more vernix you have, the less surfactant you have. So if you have a baby that is covered in vernix, you're going to watch very closely to see how well it's breathing, because if it has decreased amount of surfactant, it may get into respiratory distress. So those two things are inversely related. Again, we used to scrub this off, but now we know that it's actually there for a reason and does not need to be scrubbed off. Neurologically, they're going to develop from the cephalocaudal, meaning head to tail. That's how the development follows. And then from proximal to distal. So from the inside, so shoulders on through to their fingers. So cephalocaudal and proximal distal patterns. They do come with acute senses of hearing, smell, and taste. And they do have some reflexes that we're going to be looking for. When babies are first born, they're going to have this initial period of reactivity. So this is when they're trying to figure out their environment, they're exposed to bright lights, they're feeling sensations on their skin for the first time. They're usually alert, moving around. They may start showing us signs of hunger. And then after they've had a good feeding, hopefully, they're going to go into a period of decreased responsiveness, and they may have a good, strong sleep. They went through the labor process as well as the mom, so they may need to sleep that off. And then afterwards, we should see newborns waking on a very regular basis, looking for feedings. And so we do not want these babies to be sleeping more than 4 hours. We need to wake them up. And babies that are 36, 37, 38 weeks are late pretermers, don't do such a good job of waking themselves up to feed. It's only babies that are more neurologically mature, so closer to term or so 40, 41-ish weeks, those babies are going to wake up on their own. But as caregivers, we need to wake them up and feed them a minimum of every 4 hours. We don't want them sleeping more than a 4-hour break, because then we know they won't get enough calories in. They do have response to stimuli. So if there's a lot of people in the room, a lot of activity, a lot of passing around to different family members, that is going to stimulate them and keep them from moving in and out of those sleep cycles. And so we want to keep the stimuli down a little during the sleep times, and then have them awake and alert and contribute to that stimuli. They also have some self-quieting abilities. They can console themselves if they're given the tools. One of the things that they are very used to is their hands. And as kind of as a society, we've learned to swaddle our babies and tuck their arms down tight. But really, they need their hands as part of their self-consoling ability. And we need to allow it. So if we're going to swaddle them, we want to let them have their hands. Now I'm going to move into the nursing management of the newborn, so more into chapter 18. I've talked a lot about transition already. We have these major events that need to happen. Our initial newborn assessments are going to include things like APGAR scoring. We're going to be measuring length and weight. We're going to look at vital signs. We're going to try to determine, does their gestational age assessment match what we think their gestational age should be? And we have some different tools that we can look at. You don't have to memorize this, but we have some tools that we can look at, some assessments to determine about where they are. And we can get within about 2 weeks of their gestational age based on this assessment. So when we look at our APGAR score, this is just a simple scoring system, an assessment that's done of how well the baby is transitioning from intrauterine life to newborn life. And we are going to give a measurement for all of these things: appearance, pulse, grimace, activity, and respiratory. Each of these things may have a score of either 0, 1, or 2. So our lowest score that's possible here is 0, and our highest score is going to be 10, because you can give a 2 for everything. Most often we see babies somewhere between 8, 9 at 1 minute, and hopefully 8, 9 at 5 minutes. And those are the time frames that we're going to do. We're going to give them a full minute to transition, and then we'll assign the first score. And it's just a quick way of communicating information. If I say that I have a baby that has an APGAR score of 5, that means that I am providing quite a bit of assistance to allow this baby to transition. But if I have a baby that has an APGAR score of 9, that means that this baby is transitioning well and does not need any support from me other than just continued monitoring. It's very rare to have a 10, because babies typically are not pink all the way down through their extremities in the first minute, or even in the first 5 minutes. And if we have a score less than 7 at our 5-minute mark, we're going to keep going until we get a score over 7. So let's look at these two babies. You can see here, this baby is pink, it's crying, it's grimacing, it's got great tone, it's flexed. And so if it's crying, it's breathing. And this baby is going to be somewhere in the 8 or 9 APGAR score. This baby is flaccid, it's blue. It obviously doesn't have a good respiratory support. That's why we're moving toward the respiratory here. It has no grimace. So this score is probably, depending on what its heart rate is, somewhere 4 or 5. Not a great score. So this baby needs some resuscitation. Also, this baby has a classic preterm stance. We call that the frog-like posture, because its muscles just aren't developed enough to be able to support it. So this is a classic look of a preterm baby. We're going to be measuring them. This doesn't have to happen immediately. In fact, we prefer to leave them uninterrupted until they have their first feeding. And then once the first feeding has happened, then we can do their measurements. And we're going to measure from the crown of their head to the heel. We do have to stretch out that leg to get the heel, and that's their length. We're going to do their weight in grams. Remember, we're going to put something warm underneath. Some of these scales actually have little heating mechanisms on them. And then we're going to do it in grams and then in pounds, so that our parents here in the US will recognize what that is. Then we're going to measure their chest measurement in centimeters, and that's usually right at the nipple line. We're going to measure their head, and that is at the crown of their head, right above their eyebrows. All of these measurements are just going to be done once. It's for multiple reasons: to make sure, A, they're within normal limits. We have to know what our normal reference ranges are, and then B, as a reference tool, so that if something is abnormal later, then we will, like in the next few days, then we'll be able to compare. So as I talked about gestational age before, prior to 37 weeks, we're going to call preterm or premature. 38 to 42 weeks, we consider term, but we are not going to support or try to intervene or to contribute to labor happening until that baby is 39 weeks. So no inductions electively, and hopefully not contributing to labor, like adding oxytocin or that sort of thing, until we have at least met our 39-week threshold. And that's a change that I've seen in the last 20 years. That's an evidence-based change. Post-term is going to officially be after 42 weeks. You typically will not see anyone reach 42 weeks. It's kind of an unusual situation. And then post-mature is after 42 weeks with signs of placental aging. So these are just some different pictures of babies. This baby is term. This baby is late preterm, probably on the premature side, and this is extremely premature. So you can just see the differences in development. This is that Ballard score that I mentioned. It's one of the tools that we can use to try to determine the gestational age, and these are all the things that we measure. And like I said, we can get within about a week and a half, 2 weeks of these babies. It's a pretty good tool. Here's a quick assessment that you can do anywhere that you're working. So for instance, let's say you're working in the ER and you have a baby come in, a mom come in and deliver very quickly. If you need a quick and simple assessment, you can look at the bottom of the foot, the sole of the foot. A fully mature baby that is term, so 38 weeks or more, is going to have creases all the way down its foot. And these creases move down as it matures. So if this baby was late preterm, we probably would be missing the creases that are in this area here. This is a premature baby, and you can see the difference. The skin is translucent, it's very thin, and it has no creases. So this is a quick, easy assessment to determine approximately what your gestational age is. And why you would want to know is this baby is most likely going to need some respiratory support imminently, whereas this baby may or may not, because it probably has the surfactant development. So that's one of the quick, easy tools that we can use. And then we have our size for gestational age. So when we talk about small for gestational age, this is saying that this baby, for whatever reason, didn't get what it needed nutritionally in the uterus. Maybe it was a disease process like hypertension that can cause small for gestational age, or intrauterine growth restriction, IUGR, sometimes how it's referred. And then appropriate for gestational age, this is the baby that grew appropriately. And then large for gestational age, and this can be associated with disease processes like gestational diabetes or type 2 or type 1 diabetes. And these babies grew larger than they needed to be for their gestational age. So here is an example. There's a large for gestational age baby, and this is an average for gestational age baby. Moving into vital signs. Now, these are going to be different for just about every reference that you look at, and we always want to follow hospital policy. So one of the most important things we need to know is temperature. And more so than the high range is we need to pay attention to the low range. So any baby that has a temperature of 97.7 or 36.5 or below is worrisome. Why is this baby not able to keep its temperature? So low temperature could be an early sign of infection. It could be an early sign of hypoglycemia. It can correlate with respiratory distress. So low temperature is what we're looking for. Babies are not able to mount a high temperature for several days. So you won't expect to see a baby that's sick have a high temperature. And we tell moms that if the temperature is over 100.4, they should report that. This specific textbook uses a little bit lower threshold than what I'm used to. Heart rate, 110 to 160, just like it was as a neonate, and it can increase all the way up to 180 during crying. That's acceptable, but not sustained. Respiratory, we should see 30 to 60 breaths a minute, and it will increase with crying. And then our blood pressures are not typically taken on our normal newborns out on the floor. You will usually see blood pressures taken when babies need a higher level of care, like in the NICU, but these are the ranges, and it's associated with size and gestational age. So we would expect to see our systolic 50 to 75 and our diastolic 30 to 45. And we do take our baby's blood pressures on both leg and or arm, whatever is most convenient. But again, you're not going to see this on a normal newborn on the floor for the most part. There's something else going on if you're looking for blood pressures on a baby on the floor. So when we're looking at these babies, every time we come in contact with them, we're looking for, are they nasal flaring? Are these little nostrils flaring in and out with every breath? Do we have chest retractions where they're pulling their muscles in and you can see their ribs when they're breathing? Those are signs that they're using their accessory muscles trying to oxygenate. So those are signs of respiratory distress. Grunting, where a baby makes noise with every exhalation. So it would look like, or sound like. Or if they're labored breathing, you can see that they're working very hard. Those are all signs of respiratory distress. And again, early subtle signs are what our baby's going to show us. Generalized cyanosis. Remember, I talked about cyanosis anywhere around the lips or the mouth, around the chest. Those are concerning signs. Flaccid body posture or rigid body posture. Now, this baby is gently flexed, but if it were rigid and then unable to relax that, that would be a concern. Or if it was completely relaxed and flaccid, that would be a concern. Abnormal breath sounds, abnormal breath rates, abnormal heart rates, and abnormal newborn size. Every time you come in contact with a baby, we're looking for signs of infection, signs of respiratory distress, signs of dehydration, signs of hypoglycemia. And again, same picture, looking at these two different babies, you can see very quickly that a healthy term newborn is going to look very different than a premature baby that is needing some support. Here's a picture of those retractions. There's some good videos if you want to take a look at those, but these are babies that are using their accessory muscles to try to bring in enough pressure and bring in enough air to oxygenate. And this is another example. You can see the ribs with every breath, and those are called retractions. So our job in our immediate newborn period is to make sure it's always airway, breathing, circulation, make sure that airway is patent, that there's nothing blocking the airway, that the baby is oxygenating, showing us signs that the baby's oxygenating. We want to make sure that we identify these babies immediately. A nurse should not be leaving the room until she has appropriately identified her baby with two bands to match the parents. We want to maintain thermoregulation. So we're going to dry that baby off and put them skin to skin, maybe put a hat on their head, depending on where, what facility you're in, and cover them both up with warm blankets to make sure that they're staying nice and warm. And then we have some routine newborn medications. You can look at the drug guide in your textbook there, or you can look at the video about medications, but we have some routine newborn meds that we're going to give all newborns. And then the reason behind those are listed very well in your textbook. Some of the challenges that I've already mentioned: cardiovascular, respiratory, airway, breathing, circulation, and then gastro and thermal. We don't want to cold stress this baby. This baby is actually pretty pale. I don't know if you can see the difference between the mom's skin and the baby's skin. So this baby is still transitioning. It's blowing some bubbles, has some fluid there. I don't know anything about this baby, but just looking at it, it tells me already it's a little pale. And so I'm going to be watching this baby closely, because that could be a sign that we are having issues cardiovascular, respiratory, or it could just be transitioning. We never want to cold stress a baby by like doing something like bathing it, because if a baby is already working on transitioning, we certainly don't want to send it off the cliff by now making it cold with a bath. And then jaundice, bilirubin conjugation and jaundice are the things that we are looking for before they leave the hospital, so that we can head off the major issues that come with that. We'll talk more about that in a minute. So when we're doing our initial newborn exam, again, a priority during transition is let the baby transition and get the baby a good feeding. And then afterwards, we're going to make sure we understand the prenatal history, if there's anything that needs to be addressed regarding that. We're going to get those measurements as I showed you previously. We're going to do an exam and look at this baby and compare it to what we know as normal. We're going to look at the face, the mouth, the eyes, the ears. Are they in the right place? Are the eyes open? Are they set in the right area of the face? Does the mouth have any unusual openings like the palate? Is the nose patent? We're just going to take a look there. Is the neck normal shape, chest normal shape, abdomen, genitalia? We're going to look closely at the back and the extremities. Does it have the appropriate number of fingers and toes? Are there any openings in the sacral area or dimples that need to be investigated further? We're going to look at the neurological status. Does it have appropriate posture and muscle tone and alertness? And are those newborn reflexes that we're expecting to be there? And we'll talk more about those in just a sec. So as I move on here, I want to talk about some of the normal skin variations. This can be very concerning to a lot of parents because when we see skin variations as an adult, we think something's wrong. But there are some normal variations that we can be looking out for. So here we are looking at that vernix again, that cheesy substance. It's inversely related to surfactant. So we want to make sure that a baby that's this covered is breathing well. The next variation we might see are these Mongolian spots. And this is going to be related often to skin tone. Darker skin tone babies have more chance of having Mongolian spots, and they are usually located somewhere around the back, sometimes on the legs. We want to note those because later on, if this baby comes back into the hospital or back into the doctor's office, we can differentiate between Mongolian spots and bruising because they were notated that they were present at delivery. So it's important for us to document our findings. This is called milia. These are just blocked pores. We don't have to pick them. We encourage moms to leave them alone. They will become unblocked. This is not an unexpected finding. This is called, the layman's term is called a stork bite, but this is a common skin variation that we see at delivery. Sometimes they're on the forehead, sometimes they're on the back of the neck. They can get bigger and brighter if the baby's crying and fills those capillary beds, but not unexpected, nothing that we need to be concerned about. Some of the other skin variations that are permanent are port wine staining. That's what this is an example of. And this is a strawberry hemangioma. Sometimes they will look at these and follow these closely, but that's something that can be followed up with the pediatrician on the outside. It isn't something that we're concerned about. Again, we're just notating what we're seeing. It's not our job to diagnose. Look how long this baby's eyelashes are. And this is what we call normal newborn rash or newborn erythema. It is completely a normal finding. This one is actually a picture of someone that I know. They gave me permission to use this picture, and it is pretty pronounced on this baby. Unfortunately, if you have a new mom and they haven't educated about what normal newborn variations are, they might take this baby to an ER because they're concerned about what's going on. This is sometimes just a reaction to being outside the womb. It's a reaction to clearing the mom's hormones from the baby's body, and nothing needs to be done. This is not an emergency. This is a normal newborn rash, and it's going to go away on its own. I actually have had the experience where patients will come to the ER because they're so concerned about their baby, and now their baby has been exposed to everything, in the world. But this is a normal variation. Sometimes there are variations in head size and shape, and so we need to know what's normal in order to know what's not normal. Molding is a normal variation. We might see some caput. I'm going to talk about this in the next slide. And a cephalohematoma needs to be noted and will need to be reported and probably followed up. Some abnormal findings might be microcephaly, macrocephaly, or large, small, or closed fontanelles. So let's talk about each of these things. This is normal molding. This one looks like it probably had a vacuum applied. So that's that operative vaginal delivery, but this will get better. We do want to assess to make sure that this baby does not have a hematoma, and I'll talk about that in a sec. These bones, these suture lines, are how this baby has the ability to mold through and fit through the pelvis. The openings of those suture lines are called fontanelles. They're a great assessment tool. We need to be looking at them. They let us know that babies, they can give us a clue as to their hydration status. A sunken fontanelle could be a baby that's dehydrated, or a bulging fontanelle could be a sign of infection. This is normal finding here. This is caput, and this is what we call edema. So that baby in that previous slide probably has some caput going on, but this is when there is fluid that has caused some swelling underneath the skin. And we know that it's most likely just fluid and edema because it's crossing that suture line of the head. When it doesn't cross the suture line of the head, we're concerned that it's a cephalohematoma, and those are typically blood. And we do want to be on the lookout for those because we need to watch for signs of increased intracranial pressure in these babies. And here is a classic example of a cephalohematoma. So again, with this baby, we're going to be watching for increased intracranial pressure. So that might be poor feeding, persistent vomiting, high-pitched crying, flaccid, respiratory distress, a low temp, all those things that I've mentioned previously in our assessment. This is hydrocephaly. So this baby has a larger than expected head. And remember, we did that circumference, so we'll be able to know if this is growing or not. This baby will need to have a procedure to have a shunt put in order to decrease this, because eventually those skull bones are going to fuse. And then this is an example of microcephaly. So here's a normal head, and a microcephaly is when the head is much smaller than expected. And then this is severe microcephaly. This is one of the conditions that we saw with our Zika outbreak in the last few years, is that babies that were exposed to Zika virus in the womb had microcephaly. These are the newborn reflexes when they appear and when they disappear. The things that I'm really looking for early on is, do I have a blinking reflex, a grasping reflex, a sneezing reflex, a rooting reflex, and a gagging reflex? Because all of those are going to affect the ability to breathe, not so much the grasping, but those are the ones that I'm looking for. Very rarely do I look for a Babinski sign, unless there's a specific reason that we're concerned about neurological status. Those are the ones that we are not necessarily looking for. So here is the startle reflex, and we do use this reflex specifically for babies after they, if there's been a shoulder dystocia or an expected shoulder problem during delivery, because we want to know if this baby will automatically lift its arms and has the ability to use its arms. One of the risks for a shoulder dystocia is damage to the nerve that can contribute to Erb's palsy. So we do elicit the moral reflex, and we don't do it this way. We actually lift both their hands and then drop their hands while they're laying flat on a bed, and then they usually will use them to elicit that startle. Rooting reflex, grasping reflex. I don't find the stepping reflex useful. It doesn't really tell me much. Babies' eyes can be crossed and they can look very out of focus. This will get better as they continue to mature. Nothing to be concerned about. There's nothing wrong with this baby. Their ear should be normally developed on the outside, and the top of the ear should come right to that outer canthus of the eye. They should be about level with each other. When you have an ear that's abnormally shaped or located in a low position, we are concerned about that. That's one of the things that we would notate, and we would want to report this because it is associated with certain genetic conditions. This is called an ear tag, and when we see an ear tag on a baby, again, it's something that we want to note, and we want to inform the pediatrician. They might want to do a kidney ultrasound. Sometimes this can be associated with kidney agenesis or dysfunction, so we want to look further when we see these signs. So that's really our job, is to look for signs that are outside of the norm and then report them and have anticipated orders. Other common concerns that we see during transition is TTN, transient tachypnea of the newborn, that physiologic jaundice that I talked about, and hypoglycemia. So again, knowing what's normal to be able to pick out the things that are abnormal. So if we have transient tachypnea, this is when we have fast breathing and then normal breathing and then fast breathing and then normal breathing. It can be a precursor to respiratory distress. So we want to give the baby some time to transition, make sure that they stay warm. We will only provide oxygen if they meet the parameters for that. We used to give 100% oxygen to all babies, but now there are parameters. We know that our babies are not satting at 100%. There is a range of what they sat in based on their hours old and on their gestation. So I'm not going to go too much further into that here, but we don't give 100% oxygen unless it's a short term for a resuscitation event. We also want to watch them frequently. This would be, we need to stay at the bedside and make sure this is trending better rather than trending worse. And then we allow time for that fluid to move out of the lung spaces. We are also going to be watching for physiologic jaundice in those first 24 hours. Again, jaundice is the byproduct of that breakdown of excess red blood cells. And each baby is going to have its own risk zone. And we want to try to determine what that risk zone is. And there are some things that we can do early on to try to keep it in a lower risk zone. The first thing is feedings. The way we get bilirubin out of the body is to poop it out. And so the way we get babies pooping is to get them feeding. So if baby's lethargic or not wanting to latch onto the breast, maybe mom can do some hand expression and get some feedings into this kiddo so that we can get them pooping. That's important. We want to begin checking our jaundice levels after the age of 24 hours. If we happen to notice, or if we test these babies and they're in the high risk zone early on in that first 24 hours, that's pathological and not a normal finding. And so we're going to have to go further and treat that a little more aggressively. And that's covered in my other video. We might do some phototherapy if they're in a high risk zone as a prophylactic measure. And the phototherapy, these Billy lights, and I'm going to show them to you in just a second, they will actually turn the bilirubin into a water-soluble compound. Now the baby can urinate it out as well as defecate it out. And we're going to be monitoring that hydration status. So this is a bilimeter. It's a non-invasive through the skin transcutaneous bilimeter that we can do some testing with. And once we get this number and we know how many hours old the baby is, we can start developing a plan of care based on the risk zone. All of these things here increase our chance of moving into the higher risk zones. So increased red blood cell production or breakdown, which could be caused by Rh or ABO incompatibility. That decreased liver function, immaturity. So a more premature baby is going to have a higher chance that it's not breaking down those red blood cells, or there's a backup. Maternal diabetes, oxytocin in labor is a risk factor for increasing the risk zone for jaundice. Hyperthyroidism, excessive bruising. So that baby we saw a few slides back that has the caput and potential hematoma, they're going to be at a higher risk for jaundice. And like I said, prematurity. So this is what we call a bilinomograph. And when we look at bilirubin levels, they only make sense if you can put them on the nomograph. So here we're looking at how many hours old this baby is, and here is where we would document our finding. So if I were doing a transcutaneous bili on a baby that was 24 hours old and it was 9, you can see that 9 is in the high risk zone. This is high risk zone, this is high intermediate, this is low intermediate, and this is low risk. So 9 on a 24-hour-old is really high, but a 9 on a 2-day-old is actually low intermediate. So it depends on the age of the baby. So if you're giving an SBAR report, you have to talk about risk zone versus just a straight bili number because it changes. We know that the normal expected finding is the bili is going to rise for the first 3 days and then it should start to level off. And that's a normal finding. What we don't want is for it to get up into this high risk zone, which is where we're concerned that it could be toxic. And the bilirubin is toxic to the brain in high levels. So we want to avoid that. So again, lots of feedings. Hypoglycemia is, your book gives the level of 45, but again, this is going to be, and that's milligrams per deciliter, but this is going to be per policy. Some policies allow for this baby to get underneath 45 as long as we're watching them closely and making sure that we get them feeding. And if we get to a critical value, then we are going to have to give some possible dextrose gel. Some places are using that. It goes into the mouth. Or we might even do some IV support with a D10 solution. So we're going to be monitoring for symptoms. Many are asymptomatic. Some of the resources I see out there talk about things like babies sweating and being, and as a sign of hypoglycemia, but babies don't sweat. That's something that you might see in an adult, but not a baby. So things we would be looking for: hypothermia. That's the first sign that this baby might be hypoglycemic. They might be jittery. They might be lethargic. They might have a high-pitched cry, or they might not have a cry at all. So all of those signs that I've talked about before, those subtle signs, we need to be paying close attention to them. Other newborn screenings that are going to happen when they're in the hospital, we're going to do a newborn screen. Sometimes you'll see this referred to it in the old name, which is a PKU, and it stands for phenylketonuria. The hearing screen, I'm going to talk about that, the rest of these in just a second, and then your jaundice risk category, which we just covered. So this is that newborn screen. We take blood, a small heel prick from the baby, and you can see these darkened zones. This is where we would draw blood from a baby. And we don't want to go here because this area we could actually hit the nerve or even all the way down to the bone. So you put your thumb at the bottom of the baby's foot, and then you can poke on either side of that. This is a litmus paper that's going to collect these samples. This is an old picture because there's actually 7 circles now. But this litmus paper is going to just collect these little drops of blood. They get sent off to the state. This is done in all 50 states. And they're looking for congenital conditions that can be controlled, and or most of them can be controlled with either diet or medication. So we're looking very closely. This is the very complicated state form that goes along with this. We want to, as the nurse, we are responsible. Oh, I said 7, there's only 6. As the nurse, we're responsible to make sure that this is filled out appropriately, documented appropriately. And then once this gets sent to the state will then contact the parents. This is done on every baby. There is the opportunity for parents to refuse it. It doesn't happen very often, but if they do refuse it, there is a form that must be sent to the state. Newborn hearing screening program is a very interesting little device. You typically will see a tech come around and do all the newborn hearing screens. They put these probes on the baby and these little earphones, and then the machine will give a series of clicks and look for the brain waves associated with it. Now, sometimes babies will not pass first off, and they need to have that repeated. We don't want to panic the moms. It's very common actually for them not to pass. And so they will give the test a repeat in the next day or two, maybe when those ear canals have dried up a little bit. But this is, if they are doing this hearing screening and you happen to walk into the room, be very quiet because it picks up ambient noise. And we want the baby to be sleeping if at all possible, because if it's moving around and wiggling enough, this machine won't pick it up. But it's a fun test. This is the congenital heart screen. It's basically 2 O2 sats at the same time. They do a pre-ductal test and a post-ductal. So before it goes into the heart and after it goes in the heart, and then they compare those percentages. We want to make sure there's not more than a 3% difference between them. And this can actually detect some pretty severe cardiac anomalies that would prompt us to further test before we send them home. And here's all the things you need to know if this baby does not pass this test. These are the conditions that we're looking at for our course for our students that are in person. This is going to be covered more in detail in our pediatric section. Sometimes it's covered in OB, but we have a pediatric professor that's going to cover these, looking at these different congenital heart defects. You can actually go to, if you search Cincinnati heart and look up these different conditions, you can see some movies that will show you how the blood flow through the heart should be, and then what it is in each of these defects. So if you're looking for these specific things, tetralogy of flow, ASD, VSD, or PDA, patent ductus arteriosus, then you can go and spend some more time looking at those. Your book is a good resource too. Okay, now we're going to move into talking about early newborn nutrition. Remember I said that their tummies are very small. They only need breast milk or formula. They don't need any other fluid or water, glucose water. We used to do all kinds of crazy stuff with our newborns, but now we don't do that anymore. We are going to support mom's choice. We are going to give her good education that breast milk is uniquely formulated for human babies. And if she's not able to provide it, there might be an opportunity for, if the facility that she delivers at offers donor breast milk, there might be an opportunity to receive that. This is the natural feeding position. We call this the ventral position. These babies do very well if we just put them skin to skin with their moms and let them attach. We can assist and help them find their way a little bit if they need to, but they're actually pretty smart. Again, tummy size, day one, size of a cherry. They are not the size of a large egg until about 1 month. So about 5 to 7 mLs or half a teaspoon in those first few feedings. And interestingly enough, that's about how much colostrum is in the breast at any one time. And then as they move into day 3, we see that volume increase. That's about the time that the mature milk volume starts to come in based on stimulation. So nature has it all figured out. And they really aren't up to the 1.5 to 2 ounces until they're about a week old. So we do not need to stuff these newborns. They will get plenty if we just start off in those very small amounts. And this is one of the reasons that it's speculated that we see a higher chance of obesity in our bottle-fed babies, formula-fed babies, because they take what's offered to them rather than stopping when they're actually full. Again, it's a completely different process to take milk out of the breast than to take milk out of the bottle. So we want to pay close attention to their cues. So babies will give us early feeding cues. And so when they start to wake up, put their hands in their mouth, open their mouth, have their eyes wide open, these are the early feeding cues. If we wait until they're stretching, sucking on their hands, those are our mid cues. And then here our late cues are crying, agitated, turning red. Now they're hangry and they don't want to learn anything new. They don't want to be patient. So we want to try to get them with those early feeding cues, if at all possible. When we're helping our mom with breastfeeding, we have several things that we need to cover as far as education. We're talking about the composition of breast milk and how it changes throughout the feeding and throughout the day. We're going to offer any assistance with positioning and latch. One of the most important things we can do is make sure that this baby is turned tummy to tummy with the mom. We don't want this baby to have to turn its head to try to latch onto the breast, because then it doesn't achieve a good latch and it doesn't have a good suck and swallow, and they will keep popping off. We also want to talk about how to store breast milk and expressing milk, easily done with hand expression. We don't necessarily need a pump for that, especially in the early days. And then our concerns would be sore nipples, engorgement, and the potential development of mastitis. So this is just physiology again of how breast milk is made. It's based on the amount of milk that's taken out of the breast and the amount of suckling that happens at the breast. So every time we give this baby a pacifier and it's getting its needs met by its sucking needs are being met, it is not sending that message to mom's brain to say, make more, make more, make more. So babies have a desire to suck, especially early on, because they're trying to tell the mom's body, make more milk, but it doesn't work if we separate those two things. As far as the anatomy of the breast, the nipple is just the conduit that allows the milk to come out. The milk ducts are actually right here behind the areola, which is why we say babies need to latch onto the breast, not the nipple. So the suckling action here, these are like little something that you would squeeze and allow milk to come out. It's almost like a siphon device here. So the baby suckling actually presses this nipple up against the roof of the mouth. The squeezing action happens here, and the milk comes way back here from the glands and down and out into the baby's mouth. Adipose tissue has no relationship to how much milk is going to be being made. We want the baby to latch fully and deeply as much as we can. Here is just some tips on how to help this baby get this nipple into the mouth. And we do something called a latch score. And this just tells us early on how well the baby is able to get onto the breast and how much help the mother needs. So lactation consultants sometimes will use this score as a tool to communicate to each other how much assistance this baby needs to obtain a good latch. As the baby gets a little bit older, it's not really a useful score. I have this slide here because breast augmentation is something that is still done pretty frequently in our society. And so you can still breastfeed if you've had a breast augmentation with implants. Just want to talk about some of the conditions that we might see. So breast here with no augmentation. This is an implant that has been put in above the muscle. They typically go right here and cut through the cannulas in order to insert that. So if that has happened recently in the last couple of years, we may not see the recanalization of these cannulas. And so we might not be able to get the milk out of the breast. And then here, this is the implant that's been put up underneath the muscle, and sometimes damage to the nerve that tells the brain, make milk, make milk, make milk, based on that suckling, can be damaged in when this is placed there. So someone that has a breast augmentation just needs to be followed by a lactation consultant very closely to make sure that the milk is getting out of the breast and into the baby. Here is a good example of how to hand express. Hand expression is a fantastic tool to be able to get the milk out of the breast. It takes a little bit of practice. It's not a natural process, like it's not innate. You need to be taught how to do it. So there's some great videos online, but this is just a very simple version. You grab back where those glands are, and you're going to press back, compress back, and then squeeze. And then that is going to allow the milk to come out of the breast, and then you relax and repeat. Many people find it easier to hand express than to use a pump. And as they get better at it, they don't even utilize their pump. This is hand expression into a cup or into a syringe. As long as we can get the milk out of the breast, we can get the milk into the baby. So you can see that we can use a cup to, and they'll just lap it up like a little puppy. You just put it up next to their lips, or we can use a spoon. Remember, they have very small amounts that's needed. And this spoon is about 5 mLs if you fill it completely here at the bottom. And that's an entire feeding for a newborn. Remember, that's how much a baby's tummy will hold. Medication and mother's milk. Hale's book is really the best resource and reference we have for medications and mother's milk. Most lactation consultants have a subscription to this, or you'll have these books on your units. If any other part of the hospital, someone's breastfeeding and they're worried about a medication that they're taking, or a provider doesn't know whether it's compatible, they can look in this book, or they can call a lactation consultant or call the lactation department, and we can let them know if there's been any studies regarding that. This is a pump. This is a double pump setup. There's lots of different kinds of pumps. That's a whole nother class to learn about all the different pumps, but every mom should have access to one. They are required by all insurance companies to be provided to moms, and they need to know how to operate it in order to use it effectively. And then storage of the milk. When we have fresh pumped milk that's going to be utilized the same day, it can be out of unrefrigerated for a couple of hours. Again, it's going to depend on your policy. I think they say it's good for up to 4 hours, but most hospitals want it to be less than that. And then it can stay in the refrigerator for up to 24 hours. And if it's not going to be used within 24 hours, It just needs to be directly frozen. And that can stay in your deep freeze for 6 months or more. These are some tools that we can use for engorgement. Engorgement is swelling of the tissue. We see engorgement around the 3rd or 4th day, and it's usually related to, mostly related to all the fluid that we gave this mom during delivery. So cabbage is a great tool to use for engorgement. We want to get the engorgement, get some relief so that the baby will still be able to latch appropriately. This is when we see a lot of things go awry because the breast is now shaped differently. The baby's not able to obtain a good latch. And then we see damage to the nipple, which allows the entrance of bacteria. And then we can see the development of mastitis. And so making sure that we manage engorgement is a really important tool. We also want to give moms what to expect. So in our first few days, we want to see, this is just a graph that she could keep track of. We want to see at least 8 feedings in 24 hours. That's our minimum. More is fine. And then we want to see about 6 to 8 wet diapers by the time they're a week old. So knowing what to expect and knowing what's normal is imperative. And this information really needs to be given to the moms before they go home, and making sure that they understand it. Knowing that transitional stool needs to happen by day 3, we need to start seeing it by day 3. These are important tools to know that the baby's getting enough. And then with our bottle feeding or formula only feeding moms, because they may be bottle feeding breast milk, there's all kinds of combinations. We want to make sure that they know the types of formula that are available and that they need to reconstitute the formula exactly to the specifications on the packages, because those are designed to meet the needs, the caloric needs of these babies. We can't dilute them more than that, because then the babies won't be getting what they need calorically. We also want to talk about the equipment and how they clean their equipment, making sure that they're using appropriate water, making sure that they're holding this baby and having that good eye contact and even skin to skin contact. We never prop a bottle. It's not appropriate. And talking about when we're going to introduce solid foods. And the recommendation right now is not until at least 6 months. As we get ready for discharge, there's lots of things we need to cover with these new parents. We want to talk about when they're going to return, our warning signs and symptoms, and then any immunization information. If the baby did receive the first Hep B vaccine, it's imperative that we send that information home with them. It's really hard to try to recreate those yellow cards later. We also need to keep in mind their educational level, how willing they are and able they are to take in the information at this point, and any cultural considerations regarding this education. Talking about the umbilical cord and what to expect. This clamp is most likely going to be removed, and then it should dry up. We just keep the diaper down below it so that it doesn't have anything rubbing up against it. And about by the day 7 to 10, it should fall off. Again, talking about signs of infection, redness, swelling, odor, all those would be a warning sign that needs to be reported sooner than later. We do try to keep it out of the, we don't immerse it in a bathtub until it has fallen off. And then here we have a bulb syringe. This is really important for moms and dads and everyone to use, because this could save them from a 911 call. Sometimes babies have a lot of excess fluid that they're trying to clear, and that can interfere with their airway. So knowing that we squeeze it, put it inside of their mouth, squeeze out whatever's there, it can help them clear fluid when a baby's not able to clear it themselves. We recommend that they take the one that they got from the hospital home. Here we have a safe sleeping environment. This is directly out of a catalog that sells baby items. This is inappropriate all the way around. Safe sleeping environment looks like this. Babies on their back, nothing in the crib, nice firm mattress, just in a onesie or a swaddle that's made for sleeping. We also want to cover circumcision care. Most of this is done outside of the hospital in most places now. Talking about prevention of abduction, car seat safety, again, infection prevention, not letting anyone around your newborn, and bonding, spending lots and lots of times. You cannot spoil a newborn. It is impossible. And we start to build that relationship between those parents and that baby by the more time they spend bonding. Here are your warning signs for a newborn. Again, you're going to see a little bit different ranges or everywhere. For our intents and purposes, anything under 97 needs to be reported. Anything under 97.7, moms need to try to warm that baby up before they report. The best way to warm the baby up is to put them skin to skin. And that means baby skin on mom's skin, not a onesie in between. You can leave the diaper on, but we want skin to skin. That should warm the baby up. Anything over 100.4 is reportable and should be immediately. Central cyanosis, that's a 911 call. That is an emergency. Respiratory difficulties, too fast or too slow. These need to be reported immediately. That's a 911 call. Difficult to wake up, being lethargic, having poor tone. If they will not feed, it is essential that they be seen immediately. That's a sign something's not going on. If they're not waking up, that's a sign something's not right. Persistent vomiting, diarrhea, less than 6 wet diapers in 24 hours after they're a week old. So we really want to be watching those, that output, because that tells us the baby is getting enough. And then no stool times 4 days. I love these sweet little pictures. I'm just going to show you a few. That is the most gorgeous baby. I just want to squeeze her. Look at this one. Who knew? They made these little tiny guitars. And then this one, this is Angry Baby. She's pretty popular out there. I think she's probably grown up now. But anyway, I know this was a long one. Thanks for sticking with me. If you have any questions, feel free to reach out.